Guys, we need to be comfortable with having uncomfortable conversations.
Let's start with Nthabiseng.
Before you can even think about giving that person a pill, take care of the psychosocial aspect of this person.
But there are people who are already actually taking it, participating in those trials.
The communities, peoples, individuals can access everything relating to PrEP and HIV prevention, love, relationships, you name it, it's there.
Our facilities are not well staffed. Hence, we are having organizations that augment the staff that is working at the facility to help with the HIV program.
Welcome to the MAGC Wellness Podcast. My name is Kakhelo Potwane and I am your host. Today we will be talking everything HIV healthcare innovations. And in studio we have with us Selby, who will be introducing himself, and virtually we have Mathapelo and Nthabiseng, and they are experts at HIV and the new innovations that we'll be talking about. Lastly, before I forget, I know you guys are probably thinking, didn't we have Ace last season? We definitely have Ace again today, so he is also joining us. But before we go any further, I would love everyone to introduce themselves, and we're going to start with Selby, who's in studio today. How are you?
Thank you, Kakhelo. Thanks for having me in your studio. My name is Selby Mathumbu. I work for an organization that specializes with TB and HIV. So that makes me a TB and HIV clinician. I'm a public health practitioner. That makes me happy being in your studio. Thanks, Kakhelo.
I'm so happy to have you here. We have so many interesting questions, but before we delve deeper into it, I would love Nthabiseng to please introduce herself and what she does in the HIV community.
Thank you, Kakhelo. Thank you, Selby, for inviting me. I'm Nthabiseng BC. I'm a public health specialist. I work for a big organization here in South Africa, not only in this country, but across Africa in terms of research and innovations. And yeah, thank you for inviting me here today.
Thank you so much for joining us today. It is truly a pleasure to have you. And lastly, we're going to ask Mathapelo to tell us about what she does in the HIV health space.
Thank you for inviting me. My name is Mathapelo. I'm the clinical manager in one of the companies. We deal with the first 95, which is more on prevention. I'm an HIV clinician. I started working with HIV in 2010, so I know a bit about HIV. I wouldn't call me an expert, but hey, I will be an expert one day. I am also a public health practitioner. I am doing my master's now in public health, and I am very excited to be here. So yeah, thank you for inviting me.
Thank you so much, guys, for being with us today. I'm so excited to delve into the topic that we have today, which is, again, innovation in the HIV healthcare space. So before we go any further, I'm aware that Selby and Mathapelo work for NIMART. I hope I said it right. Don't argue. Can you tell us more about what you guys do there?
So with NIMART.org, basically, it's sort of a platform that we bring together all the healthcare professionals. NIMART, N stands for nurses. It's an abbreviation that stands for Nurse-Initiated Management of Antiretroviral Treatment. It was established in 2009 in South Africa by the National Department of Health after noticing that we need to bridge a gap. Doctors alone cannot be the only people that initiate ARVs to our client. We need to establish nurses to capacitate them to can be able to independently be able to initiate ARVs on our clients. So our platform, it's nimart.org. We are also a phase of CCP, meaning Clinical Care Platform. The two stand together, they work together. Across Africa, across South Africa, that's what we normally do. More on education, and we run webinars on every Wednesdays. And I think twice a month on Wednesdays. Yeah.
Okay, so now that we're already talking education on
Education.
ARVs,
Yeah.
I know that there's been some innovations in the HIV space that a lot of people are not aware of, right?
Yeah.
So, Nthabiseng, can you tell us more about the new innovations that are currently taking place, whether in South Africa or outside, regarding HIV healthcare?
Thank you for the question, Kaukelo. Well, currently the buzzword is HIV prevention. We're talking PrEP, pre-exposure prophylaxis. You know that previously and still in implementation is post-exposure prophylaxis, which is PEP for when you were exposed to possible, HIV infection, be it through needle prick injury or condom first, or one, unfortunately, if a person had been, sexually violated, you could get post-exposure prophylaxis, which would administer for like 28 days. But now we are speaking of PrEP. I think everyone talks of PrEP everywhere, but we've also seen that people don't really know how that works. So we have the PrEP pill, which is available in the public health clinics across South Africa, and some groundbreaking clinical trials had been conducted, especially in South Africa, Uganda, Kenya, some countries in Africa, on long-acting injectables. We're talking lenacapavir now, which is has an efficacy of 100%, and then we also speak of cabotegravir, which is a once every 2-month injection. It is 90 to 95% effective, as well as the dapivirine vaginal ring as well, which is 90 to 95% effective. So that is what we have. But the only mechanism that is currently approved by National Department of Health is the oral PrEP pill. It's combined amitriptyline and tenofovir. These others, the injectables and the vaginal ring, those are still under clinical trials that are, our organization, in fact, is leading these mainly across South Africa.
Okay, that is actually very, very interesting. And I would imagine that they would somehow be game changers, right, for HIV healthcare, because then you wouldn't need to take your oral pills every day. But how do you guys think the general public, number one, would respond to that? Because now everyone knows that ARVs are taken every day and everyone is comfortable with that. So how would it change the game in terms of, number one, compliance with medication, and number two, just the quality of life actually of the healthcare, of the people that are affected by HIV? Selby?
That's a very exciting question. So each time there is an innovation, it is because it is aiming at improving a particular gap in the health space. So as Nthabiseng was saying, cabotegravir injectables, even though they're still under trial, but there are people who are already actually taking it, participating in those trials. It's the injectable twice a year. So you can imagine that you were supposed to be taking an oral pill every day, and now, boom, we've got the injectable. You inject twice a year. The same goes to your PrEP. We do have injectable PrEP, but in the context of our country, we are very stringent. We don't want to just fall for everything that comes. It has to go through a particular trial, just as oral PrEP. Before it was allowed for the general public to access it, it was started by a specific population, and until the government was certain about it to say everybody else can actually access it. So it can actually improve greatly because our clients are overburdened by pills. Imagine if you have to take, firstly, you have to take a pill same time every day. That's a problem. You are not only preventing HIV or living with HIV, there are also other chronic medications that a client has. You end up having quite a number of pills at hand that we're supposed to swallow at that particular time. There's what we call drug-to-drug interaction at times. This particular drug does not interact with the other one. For example, a pregnant woman, when you are pregnant, you're supposed to take your folic, all these sort of pills that a pregnant woman has to take. You also have your depression medication that they're taking. All these pills combined. So it's a whole lot of things, but this injectable will shift away the pill burden from our client and hence improving adherence. So we are very excited about this innovation.
Okay, so I just have a question based on what you just said now. You mentioned like a trial, that like everything is actually like going under a trial. Where is this trial happening? Is it happening in South Africa? And then where did they discover this injection? And if so, if it's happening in South Africa, are we actually used as
Guinea pigs.
As guinea pigs. Actually, just not in South Africa, but then like in Africa as a whole, because then each and every discovery, it seems like the trials are often used in Africa. Is it something like, maybe if you can maybe give us like a background there, if ever you...
Wow. Actually, it's a nice question, and I would love Nthabiseng to spearhead the PrEP program, and I don't want to take the shine for her. But while she's still preparing, as I saw she stood up. So let me respond to this one. Not necessarily that we are being used as guinea pigs. So drugs that are being introduced in the country, they are regulated by SAPRA in our country. So SAPRA would not allow, they are ethical, South African Health Pharmacy Regulation. Yes, they regulate all the medication and the instruments that are medical related. So they cannot allow medication to be utilized wrongly on our clients, and hence a trial is necessary. Yeah, I think Nthabiseng is back. Maybe she can add on this one. Yeah.
Sure, Nthabiseng, the question was, are we being used as guinea pigs in South Africa? In terms of, because obviously, as it had been said, a lot of the innovative medication that is out there hasn't been approved yet, right? But they are being trialed in South Africa and in Uganda and all these other beautiful places that you have mentioned. So Ace actually asked, why do a lot of trials take place in Africa? Are we just guinea pigs?
Sure. That's a very
That's a valid.
that's a very painful reality. You know, in November last year, I was attending an HIV Clinician Society conference, and we asked this question to say, well, speaking on HIV prevention, to say that if we have all this beautiful stuff going on, they've all been researched in Africa, but it seems like the first world countries are the one to actually get these, prevention methods and or licenses. How is it then? It's an unfortunate truth. It's a highly political game wherein, it's big people with big money that decide. And it is really unfortunate. However, I'm very hopeful from the researches that have been done that 2027, we will start seeing the long-acting lenacapavir, coming to South Africa. Expensive as it is, that twice yearly injection, it's very expensive per person. It goes to 360K per annum per person. So you can imagine, because it's 180K an injection. But we wait to see. And yes, this is what it is currently. A lot of researches are done here to inform interventions that would be implemented in developed countries.
I had a privilege to work in a research site, and we are not used as guinea pigs per se. Yes, for us to say this is working on people, it has to be um, tested on people. Remember, we don't start by testing it on people first. We would use the lab rat and other methods before we can actually take it to the actual people to be tested on. And now we are saying a lot is being taken, it's being tested in South Africa and sub-Saharan countries. Where does the HIV, where is it most prevalent at? It is in the very same sub-Saharan countries. So do you expect us to test these HIV drugs in a country with a low prevalence of HIV? No, it will be tested in a country with high privilege of HIV because of that's where we will get our people from. We need to be treating these people, hence we need to be testing these drugs on these people. The same as for, say, maybe we are researching a drug of gonorrhea. We cannot take somebody without an STI or without gonorrhea to test it on because of how it's not going to give us results. So we need people who are HIV going to for the PrEP purposes. We need people who are going to be taking these pills to prevent HIV. And for those who are HIV positive, we would need to test on those to see if the current or the drugs that we are working on are going to be improving their lives or not. And we don't just test on people, we get their permission. And they know that they are welcome to leave the study at any point. So it's not a matter of people are forced or stuff like that. If at month 2 or month 3, I feel like, no, I don't want to be part of the study, I can happily drop out of the study. Thank you.
I actually like how you explained that the
Sub-Saharan Africa.
sub-Saharan Africa region really is one of the leading in terms of HIV, and also people still getting HIV, getting infections. So it actually makes a lot of sense that that would be the place where you would want to trial out new drugs. What I want to know, Mathapelo, as well is, has there been any mental health effects from these new drugs?
Taking drugs, be it ARV, hypertension, or any kind of medication, may have a side effect on you. One, pill burden. By the way, I'm diabetic. I am a very proud diabetic person. I'm diabetic, and the reason I keep telling people that I'm diabetic, I am not always compliant on my treatment. Not because of I don't want to be compliant, but because of pill burden. Taking a pill on a daily basis, it's very strenuous. So mentally, at some point, you will have some mental what do you call it? How did you put it? But you would have some stressors. Yeah, you would forget at some time. Sometimes you don't forget because of you forgot. I will look at my metformin and forget it while looking at it. That's because of yeah, it's trained us to take medication on a daily basis, which is why when we deal with people who are HIV positive, who are taking medication on a daily basis, before you can even think about giving that person a pill, take care of the psychosocial aspect of this person. Once you take care of the mental issue of this person, you have won half the war. Because of, believe me, I can take medication on a daily basis, but if psychologically I'm not well, ash, it's not going to work. I will come back with unsuppressed viral load because of I will be taking it, but I won't be taking it the way it's supposed to be. So before we think of giving the medication, let's look at the psychosocial of this person. We are the person who's taking this medication. Remember, the social beings, their fathers, their brothers, their girlfriends, their wives, their kids. So you have to think that, okay, fine. Selby might miss his dose because of he's having problem in his relationship. Mathapelo might miss her dose because of she didn't have money to can buy to can go to the clinic or maybe buy food. She needs the social support. Maybe if we support her socially, she will be able to improve mentally and be able to take medication correctly. So there are so many aspects that can contribute to the psychosocial part of the person who is on medication, and we need to be looking at that more than anything else. Thank you.
So, given the new innovations and everything else that we've been talking about, we know how hard it was for HIV ARVs to be introduced to society and for people to accept them and for people to be okay with drinking them. How then do healthcare professionals plan on now introducing this new way of treating HIV? Selby?
Firstly, there's no new way of treating HIV. Let's put it
Okay.
nicely. So ARVs are ARVs, an oral pill that most of the people are aware of. Maybe before I go into how do people accept these new ARVs, let's begin with when did our country first introduce its first antiretroviral treatment in the market? In 2004, South Africa was launching its own first line antiretroviral drug. Before, other countries had their own ARVs, but our country, because we are very stringent, we don't just take things as initially I've indicated, that our country, we are very careful with how we manage conditions. So ARVs in South Africa were introduced in 2004. Fast forward, it was not a robust drug or treatment. So clients developed some adverse side reactions because of that combination. At some point, a client would appear to have thin legs and then fat accumulation in parts where you don't expect to see fats, like a hunchback and the like. So that was already not acceptable by our clients. But did we have a choice? We were only having that combination, which we call a regimen. Then in 2004, fast forward, it was changed to the most powerful regimen, which we call, it was TEE. It was a combination of tenofovir, emtricitabine, and efavirenz. It was the best drug that we were having in the market. Clients took it, and fast forward, that TEE drug lost its strength. People developed resistance.
Okay.
As we were testing people, we realized that most of the clients were developing gynecomastia, which is the growth of the breast. You don't want a man to develop breast.
Men boobs.
Yeah, men would, so men will grow.
Not gym boobs though, but like
Men boobs. They got
Boobs.
men boobs.
So they will develop that, and which was a fat accumulation around the breast. And it was irreversible. The only way to go away to deal with it was an operation.
Sure.
So most of the clients was like, we can't cope with this. That's the first. The second side effect was suppression of central nervous system. Clients would hallucinate, and that's why most of the clients would use this drug as smoke it. That's how they were abusing it. Yes, the opiates and the likes. So
Is it a new ingredient for
yes. So
they would actually rob people coming back from the clinic and take the ARVs.
and take that ARVs.
Yeah. So
It was a while ago though.
It was a long time ago.
Yeah.
So I think your question is more, how do clients tend to accept that?
Yes.
Clients accepted, okay, it's difficult. Firstly, when you're diagnosed HIV positive, being diagnosed positive is a trauma on its own. No one wants to know that they are positive.
100%.
We are hopeful when we go to see a counselor for HIV tests, we are hopeful for good results. And when I say
whether you are positive and negative,
clients want to hear the negative results.
yeah.
Okay, but we do have those who are in a relationship who their partner is positive and the negative ones. Those ones, when they go to get tested, they are hoping that I wish my results can be the same as for my partner.
Hi, Bo. Hold on 1 minute. Wait, I need to understand what this means. So they're hoping for a positive,
We do have those clients
that want to be positive so we can be
who, when
positive
we tell
together.
them they're HIV negative, they don't believe the results. Science say you're HIV negative, but just because I slept with Selby and he's positive, then I should be positive. Meanwhile, maybe chance happened that they do not become positive, and they refuse to believe the results. We do have such circumstances, but we do have those who test positive and accept. We do have those who test positive and deny that they are
Fair.
positive, and those who are denying the results. These are the clients who need what we call treatment literacy. They want to be educated more on the issues of HIV, understand what's in it for them to take medication, what's in it for them by living with HIV. You understand? So what we've been missing throughout in the health space, we've imposing our clients to say you are positive, you have to take the treatment. But then back in the years, when a client test positive, would put them in the waiting list. We would call them awaiting for art. They were allowing them to go through the process of seeing a counselor, being counseled, until they accept, and monitoring the CD4 cell count. When the CD4 cell count drops below 200 threshold, this is when we'll introduce them on ARVs. But that in South Africa was introduced mainly because, remember, it means finances for our government. So economically, we were not really ready to manage large number of population and enrolling them on ARVs. But that was setting us back as a country. Then the government decided, now we are going to initiate everyone on ARVs, irrespective of whether their CD4 cell count is below a certain threshold. As long as you test positive today, we start you on treatment. That was taking the advantage of a person getting ready mentally of whether they want to be started on treatment or not. Because then it was more on focusing on what will benefit us as a country, which is to eradicate HIV epidemic in the country, but not necessarily benefiting the patient. Majority of clients would want to digest the fact that now I'm HIV positive. What does it mean for me by living with HIV? But in the same breath, when the clients were left to go home and think about it, most of them would not return. And then they are sexual beings. They continue to sleep with other people and infecting many more people. So I think what the government of health have decided to do in South Africa, which is to test and treat, started in 2015. It's very helpful because rather give me a package of care that I deserve. Let me go home while I'm still digesting that I'm positive. Does not take away their right of seeing a counselor every day and try to make sense for them that they are living with HIV. We understand some will stop, some will continue, whether with understanding or without understanding. So adherence, which is the question, it starts with accepting your condition. So healthcare professionals, somehow they lack the element of giving patient literacy. If I'm in a consultation room and I'm outside on the queue, there's over 100 or 60 something people who are supposed to be seen by me, I will not focus on the quality, which is educating a client. I want to check what is it that you are looking for today. Are you okay? Give the pills, there you go. So that is that in terms of acceptance.
What I actually want to ask, and I think it's very relevant in the situation that we are now as the world, right? We all know about Donald Trump, his decision making, and how it may potentially affect the care of HIV, right? So I want to talk about that. And I also then want us to think about, maybe Nthabiseng can help us with the second question, to think about Also, what's happening with Treasury in South Africa, the fact that there isn't enough money to pay doctors. So we don't have doctors or nurses or healthcare professionals in hospitals anymore because there isn't capacity in hospitals. So where do they get the counseling? Where do they get the treatment? What happens then to the healthcare of people that are affected by HIV?
And for the fact of that, like also, you're just mentioning that like you are seeing like a lot of patients, you're focusing on what they're there for and then neglecting that particular part. Probably is because of understaffed. Is it because of that situation in relation to what she's saying now, asking that like posts are being frozen in government? And I mean, like, there's a lot of doctors now that are like, looking for.
So we do have lots of qualified doctors and nurses, but remember, today we're talking about doctors and nurses, but these two are not the only professionals who don't find job in the health fraternity. Like we have a whole lot of people who are not who are struggling to find jobs. But because of this question, we are looking at clinicians, doctors and nurses. Yeah. They both are struggling to find jobs. So the question is on the impact of stop work order by Donald Trump, the US president. My comment will be very general, and I would like my colleagues also to respond on this one. So, honestly speaking, this whole thing, I think your question emanates from, I have said that we see too many patients per day. It's true. We've got a patient-nurse ratio. A nurse should not be seeing, well, it depends on the facility. At least in a day, a nurse can see maximum 20 patients. But then you tend to find a nurse seeing more than that, see 60 patients, 100 and something. We do have healthcare facilities that are very big, so much that a nurse focuses on just pushing the queue and get done. You get a pressure of being insulted by patients, thinking that you are dragging your legs. And remember that we need to individualize our clients. When you come in, your complaint cannot be the same as yours. I need to treat you as individuals. Others need to undress them. You cannot be complaining of STI and just be giving you antibiotic without checking what sort of an STI is this that I'm dealing with. So clients are different, but our clients outside, when they're on the queue, they just want magic. They just want to go home. Waiting time is a problem because we are understaffed in the government space. But then again, with the impact of this stop work order, an order from Donald Trump in the US, South Africa is dependent partially, 17% from the US government in terms of assisting with regards to TB and HIV. So with this stop work order, we are affected because then it means these health professionals that focuses mainly on dealing with TB and HIV, at the end of the day, they will be affected because it means they're staying at home for these 90 days, not going to work. It means these clinics that are focusing mainly on dealing with TB and HIV, their doors are closed now, are not operational. Tell you what, I work for an organization that specifically caters for these people. So we support the Department of Health to actually help in managing TB and HIV. And our main goal is to try and help that we initiate our clients on antiretroviral treatment when they are positive. Not only that, but when we have initiated them, they must stay on treatment, which is retention into care. Not only that, but ensuring that the goal of ARVs is to suppress their viral load. So imagine if these facilities are closed down. These clients go to the facility, they don't find the facility working. We're talking about key populations. Key populations, we're talking about the gays, the lesbian, the LGBTQI, sex workers, vulnerable population who, under general, when they go to the public space, to these general facilities, will not be treated the way they should be treated. Not to say that they get discriminated, but remember it's a generalized facility or institution. But in their own clinic, they would get a special treatment. I can quote an example. A A transgender woman would probably need hormones. When they go to a generalized facility, they don't get hormones. Sex workers, they've got scheduled time. They know that my clients are busier during this time. Yesterday, it was the 14th of February. They had more clients. And if the facility is closed down, she worked the whole night. When she goes to the clinic, it's closed. So they are unable to be accommodated as much as they would be accommodated if they were to go to that specialized facility. So what does this actually mean for us as a country? It means that we are anticipating likely an influx of infection rate going up and HIV advanced diseases. HIV advanced diseases, we are talking about a client regressing. If, God forbid, I'm living with HIV and I'm this healthy and I stop taking my treatment, we do expect that my CD4 cell count will drop. Once it drops below 200, that simply means I'm at an advanced HIV stage. That means there will be doors opening for other infections like your tuberculosis, your cryptococcal meningitis, which is infection of the brain meninges, or TB of the spine, all these complications which can actually take the patient's life away. So those are some of the things that we might anticipate to happen. Most of our clients were very spoiled because we would at some point take medication to where they live. Remember South Africa? Yes. Because in South Africa, we're not equal. Some are from the villages. There's no even network. There's no tar road. For them to get to the clinic, they have to change transport. Socioeconomic status does not allow for that. So in order for us to encourage retention of clients into care, what we would do is to try and take the treatment to them. So we sort of kind of bend for our clients. That's why the antiretroviral guideline for 2023 is talking about inclusion of psychosocial component and clinical component. We are trying to say in South Africa, do not only as a doctor, as a nurse, focus on treating the client clinically. Do not focus on giving Panado. But also ask me, how are you? How did you sleep? Have you eaten? You understand? How is the relationship? How are the things going at home? That part is mental health. If we take it away, a client will take pill but miss an appointment in their next return date because one thing, they are subjected to abuse at home. The husband is bullying them. They have not even disclosed, and you still expect them because the system will tell you that this client has not yet returned to care. When they come, you start shouting at the patient as a clinician because we are only treating the system. You are dealing with the clinical aspect. You have detached from the psychosocial aspect. So the guideline is very, very strict to say, please try bring the two together, the mental health and the clinical component together. So in a nutshell, Donald Trump's address to stop work order. Currently, as I tell you, clinics are full. Some of the nurses don't even know what to do because it seems like these NGOs were spearheading the programs. So they are not yet on their foot to actually carry over once these organizations are gone, once these clinics are gone. So that is the problem we're currently facing. Are we ready as a country? I don't think we are ready. Tell you what, by 2030, we're supposed to have ended HIV. And talking about 2030 ending HIV epidemic, these are the UN AIDS target that were set in 2014. It started with 1990 targets. Now, they were 5 years later after 2014, that was 2020, 2019, 2020. They introduced 95 targets, meaning that they've added 5% on the 1990 targets. They are so-called UN AIDS target, but they are an epidemic control target. To try and control HIV, we need to have targets set. First 90 stands for 95% of people living with HIV should know their HIV status. Talking about testing. But we are doing well with the first 90 or first 95 rather. The second 95 we're talking about, 95% of people who now know that they're HIV positive should be initiated on antiretroviral drugs, which is the reason why now they will be initiated, but the problem is, can we retain them into care? So this stop work order is affecting retention of clients into care. You started me with treatment, fine, but what now?
Yeah.
If you can't supply me with treatment, then what's going to happen?
So what I want to know now is, Mathapelo, with the whole NHI and the NGOs and the stop order, right? Say that goes away. How would the NGOs that you guys work for the key population, how would they feed into the NHI?
Before I touch that the question you asked now, I will like to go back to the second question that you asked that was in relation to adherence in a way. Ne? How does the healthcare worker bring the new innovation in order to make sure that our clients take treatment? I would like to take you back to the introduction of HIV. When many of us started to know about HIV was associated with death. So when you were HIV positive, it was said you are going to die. That's where the fear came into play. And unfortunately, to this day, we are still struggling to take away that fear part, because of that's how HIV was introduced to the people, to say, you know what, when you are HIV positive, you are it's either it's for the prostitute, you are sleeping around, and you're going to die. So instead of giving the relevant information in relation to HIV, maybe by then we didn't have all the relevant information we needed. Oh, my battery's about to die. Maybe we didn't have all the relevant information, but at the moment we do. I'm seeing something on TikTok of which I love a lot. I see people who are HIV positive, they would be saying, I'm taking my treatment. People are proud of taking their ARVs, and that raises awareness to the rest of the world, to the rest of those who are HIV negative, to say, when you become positive, we no longer die. There is treatment. Now, the stop order, Gamalu. Okay. As South Africa, we are not ready to can start initiating ARVs on our own without the outside help. I saw somewhere they said the outside help accounts for 17%. I would like to believe that is not true.
Arnold Motsoaledi said that, actually. He said people must not be scared. HIV care is not going to be affected because it only... Arnold Motsoaledi said that. I saw that as well, yeah.
Yes, I saw that as well. And this is me. This is my personal opinion. For me, that didn't sound realistic because I'm looking at our facilities. Our facilities, they're not well staffed. Hence, we are having organizations that augment the staff that is working at the facility to help with the HIV program, right? So now when Trump said, stop work now, those people had to be pulled out of the facility. So in most cases, what were they doing? They were handling the HAST program, which is the HIV, AIDS, STI, TB program. So they were handling that. Because of short-staffed, we have our department nurses who are clued up on how to initiate treatment and manage treatment. But because of the shortage of staff, you'd find that the nurse is working in hypertension department or is working in another department, not...
Oh, I think we lost Mathapelo, as she was speaking, she did say that her battery is running low, but I think she's very right in the sense that South Africa is genuinely not ready to not have foreign support right now, right? And she is also correct that there is a lot of awareness that's taking place on social media. You know, people are going out there talking about the HIV statuses, talking about how easy, not how easy, but how doable actually it is to live life with HIV, how doable it is to live life, you know, taking your ARVs, and how you can live a normal life. So Nthabiseng, I just want to ask you, there is an alarming rate in the infection of teenage girls. There's an alarming rate of HIV infections in teenage girls. So I just want to know what you think about this trend, what you think could be contributing to the trend, and also what you think can be done about this trend.
Thank you for the question. Indeed, I'm lucky to have headed the Adolescent and Youth Friendly Services Program in Tshwane District from 2019 to 2024 until I moved into the HIV prevention project. So yeah, I worked with healthcare facilities, with communities, with young people, but we rendered HIV care to adolescents and youth that is 10 to 24 years of age. Those that are living with HIV. And so we administered an HIV water retention in care strategy for them. And it was really interesting to learn of social determinants of HIV among adolescents and youth. What makes them get HIV? And it's a variety of factors. And when you look into our sustainable development goals, I mean, now 2030, together with our NDP, that say for those under age of 20 years, they must be an HIV-free generation. But then you look at where we are coming from what Selby was saying from 2014, when we now accelerated at a larger scale the access to HIV care and treatment. It goes deeper. And if we fail to look at systemic issues, structural barriers and determinants that lead to people behaving the way that they do, then we are not going to achieve those outcomes of universal health coverage, and which is a higher life expectancy and improved lives for people. So I looked at all the SDGs, and you can see how interlinked they are. One cannot do without the other. Goal 3 cannot do without the eradication of poverty, etc. Look at South Africa. What's the rate of our unemployment? And it's really sad. And however, we do have very interesting initiatives that the government has taken it upon itself. National Department of Health has this a mandate of adolescent youth-friendly services in healthcare facilities. It's also called youth zones. I'm sure you've seen some bright colors, happening around clinics. So they get launched. I can proudly say in Tshwane, I think Gauteng has over 100 healthcare facilities that are youth-friendly. In Tshwane, we are currently at 55 to 60 out of 73 primary healthcare facilities. And why youth-friendly facilities is so that young people feel free to come to the healthcare facilities and use the services that are available to them by youth-friendly staff, and they actually get the services that are comprehensive to their needs. I will always refer to the principles of universal health coverage, which is access, which is equity. People need to receive the services that they need and deserve and can afford, services that are always available, services that is acceptable to them, that actually address their needs. So yes, it's like we're dealing with a huge elephant, but there are little pockets of relief for that. But we can't win this fight if we don't all pull together as society. And it starts from the home, the values that we instill in the children. It It starts from the self before you, we call it safer conception in health. Who do you decide to have a child with? When and why? And what do you plan for this child? And then moving forward. And you know that the cycle of poverty is repetitive. It becomes engraved in one's DNA. If you were born by a hungry mother, Luena, you will continue just like that. We cannot continue Gatsila Eo. We need to think differently. That is why we say there's even behavioral mechanics that young people can engage in. So the youth zone space allows for that. So young people can come through into a healthcare establishment and be able to freely talk about the issues that they are facing to youth-friendly staff, where they will get the support and care that they need. But as a country, we cannot go on like this, where every week young girls, adolescent girls and young women, their HIV incidence is quadruple that of their male counterparts. It cannot be. We need to address all it's very hard. We cannot win them all because these things are systemic and structural. However, we need to try wherever we are to address these issues.
100%. I think it's so important actually that information gets out there, because the more people know, the more they can do. When you know better, you do better. I think today was incredibly informative, and I have definitely learned a lot of new things, which is not very often. So I am so grateful to have had all three of you actually here today. And please, guys, go get tested so you know what to do, so you can get the counseling that you need, and so that you can get the help that you need. And as you've heard, there's exciting things coming in HIV health care. And as parting words from both you, Selby, and Nthabiseng, I like calling them final words of wisdom. What would you both like to say?
Let's start with Nthabiseng.
Okay, from my side, I would say I'm speaking from the door, prevention. Selby is more into care and treatment. We do not need to become HIV positive now, not anymore. In 2019, during COVID, 2020, the National Department of Health started scaling up the availability of pre-exposure prophylaxis. That is a pill to prevent. There is no need, guys. I would like to tell the community and the society at large that if you are sexually active, and if you don't know the health status of the people that you are having sex with, or if you know and you know that they are not virally suppressed, go and get yourself prepped for as long as you are exposed to HIV. But also remember that PrEP prevents HIV, doesn't prevent pregnancy and STIs. So you still need to go dual. Use condom with the HIV prevention pill. And this is your life, especially to young people. This is your life. How koloti opi, leave it for you, protect yourself, and get informed. I think you'll give us an opportunity, but there's a couple of websites that I can recommend for people to access for more information. bewisehealth.com, especially for young people. It's interlinked with MyPrep. So it's all www.bewisehealth.com. The other one is www.myprep.co.za. There, the communities, peoples, individuals can access everything relating to PrEP and HIV prevention, love, relationships, you name it, it's there. So at the end of the day, whether government decides this, Trump says he's pulling out his stuff, his money, and NGO aid is limited, your health is still in your hands. You decide what to do with it, So people need to take care. Take PrEP. Thank you.
Thank you so much, Nthabiseng, for your well of knowledge. You are incredibly. I've learned so much from just engaging with you today. So thank you so much for your presence, and thank you so much for joining us today. And Selby?
From my side, I think it's not enough talking about PrEP without talking about post-exposure prophylaxis. The two work hand in hand. Yesterday, was it yesterday, the 14th of February? When was it?
Guys, I don't know.
It was,
Friday.
yeah. You know what? Yeah. So all I can say, Mina, is that as Nthabiseng, look, let's talk about prevention. Prevention is key. You know, many people now are disclosing that they're living with HIV. So you can always find somebody to identify yourself with. But why not prevent it if you still have an opportunity to prevent it? We can't only talk about the aspect of taking PrEP, but also let's talk about the aspect of taking PEP if you have been exposed. So the 14th of February was just, 2 days ago. You're still within 72 hours. 72 hours is an emergency. If you know that you've been exposed, you have had sex with somebody that you don't know their HIV status, or you have had a condom burst, I would encourage you to actually go to the facility. Let the nurses know. They will not stigmatize you. They will not judge you. It's your right. You are protected by the policies within the Department of Health space. Go ask for post-exposure prophylaxis. Don't be embarrassed.
Don't take
It's
a
your
shower
right.
as well, because a lot of people, once the time this shower thing came, they took it and they ran with it. Till today, there are people who are actually still saying, after doing that,
Yeah.
they must take a shower. It doesn't work. They must go and visit our
Yeah.
And also, I think, guys, we need to be comfortable with having uncomfortable conversations.
Yeah.
So, Ace, I think we can say the word sex. After people have sex, we need to be able to have these conversations. And I think part of the reason why there isn't enough knowledge and why people are not talking and why people aren't confiding in their loved ones is because we are so scared of having uncomfortable conversations. Ask your partner, have you been tested? Don't be scared to say words, guys. Sex, HIV, there are things that exist. We are doing, you know what you are doing. So please, guys.
Exactly.
And again, Selby, thank you so much. You also have been a while of knowledge, and I think having you in studio actually has been so much fun. Aura, the little aura there. And guys, for my final words, prevention is better than cure. And if you are infected, please take care of yourself, get the necessary help, necessary counseling, and if you think you could be exposed, visit your nearest healthcare facility. And I promise you, HIV is not the end of the world.
Yeah. Just a short quiz for everyone that is actually here on studio. It's just like short 5 questions, right?
It's you, Selby.
Okay. Yeah. It's for Selby and Nthabiseng is not
Okay.
Selby. Yeah. So can you get HIV from sharing a meal with someone? I think
No.
sexually positive.
No, you can't.
It's not, no?
Yes.
So that's no? And then people living with HIV can lead a healthy, normal life with proper treatment, right?
True. Yeah.
Okay. And then the other one, only a certain population are at risk for HIV.
False. We all are at risk of HIV infection. In fact, the married people are because married people tend to think that
I'm the
since
only
I'm
one.
married and I have not to use a condom, because what will the condom be for if
We are procreating.
if I'm married? And that's where the risk is. So actually it's for everyone. Everybody can
So
get
when
HIV.
you must use a condom with your partner.
Yes, please. I will
Ace.
encourage condom utilization, unless if you are planning to make a baby and you know of your HIV statuses that it's negative.
Right.
I know I will be stoned for this, but the reality is
most of the you right now.
most of the clients who are in the hospital whom we
They're
are nursing, are
married.
taking care of them, they are married. They'll tell you that I don't know where did I get this, because this is the partner I have been with
Since
since when I got married. But where did I get this? So I would encourage people to also use a condom, not unless they are aware of their HIV status. Yeah.
Yeah. So the fourth question: PrEP can reduce the risk of contracting HIV if taken correctly.
Yeah, that's true. That's
Okay.
true. If taken correctly.
Yes, if taken.
Yes.
correctly.
Yeah.
Question. So once someone is diagnosed with HIV, they can't ever stop taking medication. True or false?
Okay, so if someone is HIV, I know you want me to say true or false. I just want to make sure I'm not answering it wrongly. If someone is diagnosed with HIV positive and they are started on treatment, they can never stop taking treatment, because if they stop, the virus will skyrocket. That means more opportunistic infections for them, and that means now they can complicate and die. Yeah, so don't stop taking your ARVs until cure is found and is announced. So far, I can tell you in black and white. Oh, since we're not writing, I can tell you that there's no cure, but we've been hearing a lot of stories, a lot of articles that are being written. But if it's not announced by the National Department of Health that a cure has finally arrived, do not believe anything that you hear from the social media spaces. I've seen many people texting me, sending me messages that have found cure. So far, I can only talk to what is in the guidelines, and there is no cure as yet. Yeah.
Okay. I think that's it with the
No,
question.
thanks a lot, man.
5 out of 5.
And guys, remember that in this instance, ignorance is not bliss. Get tested. From myself and the team, it is goodbye till the next episode. Mwah.